Hello, 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 hello.
So I have one announcement before we start the seminar. We have L. Davis Symposium on November 6th. If you don't have registered, please register for that. It's an excellent event. Make sure that actually you attend. So today's speaker, we welcome Dr. Jerrold Levy from Duke University. He's a professor of surgery and professor emeritus at anesthesiology and is a clinician scientist at Duke University. And he's also adjunct professor at UBC in pathology lab medicine. And he's also a chair of the subcommittees for International Society of Thrombosis and Hemostasis. And Dr. Levy completed his MT from University of Miami. And then his first academic appointment started in Harvard Medical School. And then he moved to Emory University and then moved to Duke University in 2013. He has a long list of accomplishments and he's an authority in thrombosis and coagulation area. And he has 675 scholarly contributions that include 268 original articles, 11 case reports, 190 review articles, and he has a H-index of 111. And he's a well-cited author in this field. And he's also visiting professorship in almost 25 or 30 universities. He has a long list of awards. Actually, he has given me a 50-page CV. So I'll give you mention like a couple of them, which is the Fellowship of American Heart Association and also the Fellowship of Society of Critical Care Medicine. Actually, these are the important ones. And he is also associate editor for JTH. And also kind of like I would also like to mention, actually, we co-authored one review article in last year and 2 years back. And welcome, Dr. Levy, TBC and CBR.
Thank you. Thank you very much. Usually you wait to the end to see if you like the lecture and a clap, but thank you for the pre-clap. I'm Jerrold Levy from Duke University, and now I'm actually just joined as an adjunct professor here. A privilege to be part of this, and I want to thank all the faculty for their support. My disclosures are shown here, and been involved in developing purified, recombinant, and other strategies for critical illness coagulopathy, bleeding, and a long-standing history of doing this. So the learning objectives today include, what I want to do is examine mechanisms by which acute infections cause coagulopathy, endothelial injury, and inflammatory responses. There are important different aspects of critical illness, talk about clinical implication, and just review some of the many potential therapeutic approaches, some of the work I've done as well as others. So interestingly, it's long been known there is important crosstalk between acute infection and coagulation. It's called thromboinflammation. And probably about a quarter of a century ago, it got to be a very popular concept with all of the different therapeutic trials for treating septic patients. Furthermore, it's important to understand how acute infections and acute injury causes coagulopathy. And one of the important perspectives is that it's not a static concept. If you look at the bottom on the x-axis, that the therapy and the onset depends upon time. The important point, though, is if you see the acute peak shown here, let's see, yep. The acute peak of the hypercoagulability occurs during acute infection, because what the body wants to basically create clot and isolate and wall off this invading infectious organism. Then it migrates to a thrombotic perspective and changes over time. And the timestamp is critically important, understanding it, because the early intervention is important, especially for potential sepsis. So the thromboinflammation and infection is triggered by sort of an innate immune system. The body has all this evolutionary perspective of direct and indirect mechanisms, and activation occurs by a cascade system of both humoral proteins, complement contact activation, fibrinolytic, but as well as multiple cellular responses, ranging from white cells, platelets, as well as endothelial cells. And all of these produce a very dramatic thrombotic inflammatory reaction. Sepsis infection is a major cause. Interestingly, through the years, it's also been described as immunothrombosis. But the thromboinflammation sequelae occur in a variety of important critically ill scenarios, specifically in a disseminated intravascular coagulopathy, DIC. Sepsis is the most common cause. We'll talk a little bit more about the causes, but ischemic reperfusion injury is also part of that, as well as other ischemic events. Dealing a lot through the years with extracorporeal circulation, cardiopulmonary bypass, extracorporeal membrane oxygenation, and mechanical circulatory support. These non-endothelial surfaces provide a very large interface, as well as the things that occur in each of these unique experiences that cause a profound coagulopathy. And then there are a series of other scenarios that are also important of infectious and other perspectives, including some of the thrombotic microangiopathies. Now, immunothrombosis sometimes is intermittently been sort of described as thromboinflammation. And it's a subset of thromboinflammation that's focused on basically one of the sepsis score, the platelet count, the prothrombin INR, and your basically SOFA score. This SIC can progress to overt DIC, but early intervention allows you potential benefit of clinical therapy. And in acute infection, the most important thing you do is treat the patient with antibiotics. So about 6 to 8 months ago, we updated the 25-year-old DIC score definition to actually describe it as an acquired life-threatening intravascular disorder characterized by systemic coagulation activated, dysregulated fibrinolysis and endothelial injury, resulting in a final common pathway of microthrombosis. DIC arises from various underlying causes and progresses from an asymptomatic early phase sepsis-induced coagulopathy, hypercoagulability, to an advanced stage with hemorrhage and/or organ dysfunction. And again, this is, I think, important, the early capture versus the evolution of the process with multi-organ failure. So one of the things to remember is that in normal hemostasis, and remember, hemostasis means stopping bleeding, there are critical considerations of vascular and endothelial regulation. This is a human internal mammary artery. This data came out of my lab when I was at Emory. We did this work with David Harrison, who is now director of cardiovascular research at Vanderbilt. Here you see this vascular smooth muscle, and the endothelium's been stained immunochemically for nitric oxide synthetase. The endothelium is an amazing source of anticoagulation, vascular regulation, and as we age, we lose this incredibly important vascular endothelial surface. Just to show you one of my favorite sort of graphic illustration of all the things that the endothelium does, this is Sean Jackson's review article in Blood, 2019, pre-COVID. Actually, the title of this was Thromboinflammation, but it really describes some of the very complex antithrombotic functions of the vascular endothelium. In particular, we talked about nitric oxide and prostaglandins, both NOS and cyclooxygenase generate these important mediators. They inhibit platelet, neutrophil activation, but also as you increase flow, they provide vascular vasodilation. On the surface of vasculature are this complex heparan glycosaminoglycan structure for which antithrombin binds, further causing the anticoagulation that occurs. The surface also has PAR1 receptors for binding thrombin and a variety of other important mechanisms by which you will scavenge both thrombin and have an important anticoagulant effect. Furthermore, causing the releasing of tissue plasminogen activator, releasing fibrinolysis. Again, the endothelium has an incredible anticoagulant surface and is really important for our long-term survival. Just to look at some of the work that I collaborated with Dr. Iba on, this is a kind of animal model, but it's still a nice illustration of the venial versus the arterial. In the actual arterial, you can see the glycocalyceal kind of structure. Here's the endothelium. And you can see all of the actual normal pathophysiologic response. The blood's rushing through quite rapidly in this microcirculatory kind of a model, and you can see the relative linear S-type flow. So when you're acutely infected with sepsis, there is major effects on vascular and endothelial regulation or dysregulation, if you will. Again, one of Dr. Iba's amazing slides shows you the complex thromboinflammation and sepsis with all the pathways that are activated, both mononuclear, polymorphonuclear cells, and platelets as well, where all of these things are activated by multiple pathways, including complement, including direct activation, including many of the other kind of issues that produce this tremendous release of inflammatory mediators, again, in response to acute infection. Releasing these substances cause certainly not only vascular endothelial injury, as well as perhaps killing of the organism, but also increased capillary permeability and a variety of microthrombotic effects. and pretty much create thrombosis in the microcirculation. Just looking at a little bit of a close-up, that glycocalycyl structure is markedly injured. The neutrophils and others produce direct injury, and you see the incredible, again, microcirculatory abnormalities that occur. Looking at this, again, this model, once you've injected endotoxin in an arterial type system, you can see this sort of transmigration of all the polymorphonuclear leukocytes. You see a leukocyte platelet kind of aggregate. You see the disrupted flow and the sort of, you can actually now depict some of the perhaps red cells and loss of the glycocalycyl structure. Again, going on to eventual microthrombosis. Pretty profound thromboinflammatory injury. So when COVID came along, the coagulopathy and the endothelial injury and acute lung injury was consistent with what we've previously described, but some of the unique entrants of the organism and other sort of issues, I think, are important to consider. In COVID-19, because the viral system came in through inhalation into the lung, into the microcirculation, it had a direct pulmonary effect. And as a result, the hemostatic signature and the symptomatology was perhaps a little bit different without any kind of pre-existing immunologic memory, as well as to the fact that there's no immediate kill like there is with antibiotics. There was marked microcirculatory injury and actually in the pulmonary microcirculation. Injure the endothelium, not only do you get loss of endothelial function, but von Willebrand factor from the Weibel Pilati bodies are released, further adding to the profound hypercoagulability that occurs. Furthermore, when you look at some of the postmortem, and this is some of the early COVID work, and I'm going to just focus on the lung, you can see the microcirculation just chock-filled with mononuclear and polymorphonuclear cells. And when you do capsase staining for apoptosis, you can see the marked injury and cellular infiltration into the vascular endothelium. My former co-colleague at Mass General, Richard Hotchkiss, a DIC and sepsis researcher at WashU, was early on to show that in acute infections, sepsis per se, you see that sort of apoptosis of cells, endothelium, and also as polymorphonuclear and mononuclear cells that occurs. So it markedly alters your immunologic responses. Interestingly, just looking at lung histopathology, both looking at H1N1, which was the viral kind of flu, if you will, versus COVID, they all had similar 90% alveolar damage, but the microthrombi in COVID was about 2.5 times greater than that of H1N1 with pre-existing immunity, with antivirals, et cetera. And again, the lung injury is a really overwhelming problem that we had in COVID with the prior lack of immunity and without good antivirals. My mentor, Warren Zapal at Mass General, who was the ICU director who I worked with, showed actually 42 years ago, the pulmonary vascular lesions of ARDS. And this microthrombotic issues that he saw, thromboemboli, micro and macrothrombi at autopsy, is not a new finding. But I think what happened with COVID is that with the tremendous number of patients across the planet, that this became kind of like a new finding versus those who were critical care people had seen this before and the acute ultrastructural changes that occur. Interestingly, looking at microthrombus formation in acute infection, it's all consistent with what I just sort of showed you previously with all the inflammatory cells, platelets that get activated directly and indirectly, causing this incredible injury, loss of endothelial function, and microthrombosis. An old finding, but rediscovered, and with the tremendous number of patients seen, it became far more commonplace. Now, interestingly, the coagulopathy of COVID acute viral infection was really different than acute DIC and sepsis. Now, D-dimers were high and fibrinogen was also quite high. Remember, normal levels are about 2 to 4 grams or 200 to 400 milligrams per deciliter. Mild prolongation of the PT That's a longer prolongation. It came in DIC. Thrombocytopenia was uncommon. And again, remember, this was a local injury into the pulmonary microcirculation. DIC was less frequent. The problem was the early reports didn't have a timestamp. So again, if you're in the ICU long enough, on a couple of weeks on a ventilator, you're going to get a secondary infection in DIC. Really, again, you have to think about the timestamp. The increased von Willebrand factor produced injury as well as the endothelialopathy, and that microcirculatory thrombosis, all consistent with the findings we know and the normal pathophysiologic responses. So let's talk a little bit about some of the thromboinflammatory strategies. In acute infections and septic shock, clearly treat the underlying cause with antivirals, antibiotics, especially antibiotics. A lot of times the patients will come in profound septic shock. They're on high-dose vasopressors, epinephrine, norepinephrine, vasopressin, and you get the antibiotics, or you drain the actual abscess, or whatever you decrease the actual, you treat the underlying potential cause. And then maybe 2 to 3 hours later, you're off your high-dose vasopressors. But in the antiviral story in the COVID was problematic because we didn't have the ability to immediately shut off the infection. Thus, the thromboinflammatory response raged on. So getting back to the acute infectious DIC, the story of anticoagulation and thrombin modulation makes sense. Thromboinflammation is shutting it off. The problem is you have to do it early and you have to do it soon before the response increases. Then there are also interesting anti-inflammatory effects in immunomodulation I'll briefly mention subsequently. In sepsis, as well as in DIC, there have been multiple studies over the past several decades looking at multiple agents. Antithrombin, an agent that I've tried to work with for many years, activated protein C called Zigris. Recombinant thrombomodulin was studied in the US, North America, as well as in Japan. Tissue factor pathway. A drug that I worked with called iridoran, which was actually a TOL4 receptor and an endotoxin antagonist. The problem with all of these therapies is that you're treating patients after the event. The injuries occurred, and now you're giving an anticoagulant. However, early intervention and coagulopathy may be important as part of this. Let me briefly talk about antithrombin, because I've spent 30 years trying to figure out what to do with antithrombin. I think we're still trying to figure it out, but it's a very interesting molecule. Antithrombin circulates at about 2.4 micromolar. It's probably the largest of the anticoagulants that circulate in our blood. It's an alpha-2 glycoprotein, large molecular weight, and I'm showing you the different activities. When you substitute or replete, you have to understand some of these. It has a several-day half-life, and it's a really important protein. You can be heterozygous for the protein, but if you're homozygous, you don't survive into birth. So this is a very interesting commentary of a review article that I wrote with Nigel Key, a hematologist at UNC who I've worked with through the years, that really focuses on understanding circulating coagulation levels and their role. I also work with a scientist called Bruce Solinger, who creates aptamers. He takes aptamers, basically an RNA strand where you create a molecule that will bind to anticoagulants, the different factors, to inhibit them, and worked a lot with his 9 inhibitor. The prothrombotic molecules that circulate at the highest level include fibrinogen at about 8 micromolar, again, 2 to 4 grams, then followed by prothrombin, which circulates at 1.4 micromolar. Why? Because of the critical role that thrombin plays in thromboinflammation. After you clot, the thrombin levels keep increasing because it modulates this sort of inflammatory response, increases vascular permeability, releases mediators from mast cells to allow for chemotaxis and chemokinesis, and it's an incredibly well orchestrated system. Now, the anticoagulant, as I mentioned, antithrombin is at 2.4 micromolar, and then followed by heparin cofactor 2. But a very interesting protein that is still sort of curious to figure out. Now, one thing missing from this is where plasminogen circulates, and plasminogen circulates at about 1.5 to 2.0 micromolar. Plasmin is a very important mediator, as I'll show you, in many of these responses, and its role is also, I think, part of this complex response. So let me just show you one of the older, about from 25 years ago, a study of antithrombin and septic shock. This was called the Kybercept study. 2,300 patients were randomized to either antithrombin at high dose for several days versus placebo. Now, the idea of this study came from a study in France from the late 90s, Fourier and colleagues, that showed when you gave high-dose antithrombin, had a significant reduction in mortality. You can see that there was really no difference in mortality. It was about almost about 30% or so, in actually 38, 39, 40%, and no difference between the two groups. But when the patients who did not receive heparin, they actually was a slight difference in terms of mortality. Furthermore, when you looked at the patients who didn't get heparin but had DIC, there was a statistically significant and clinically relevant reduction in mortality. At 30 days, it was about 25% versus 40%, which persisted on at 90 days. One of the interesting things, and again, patients without DIC, there was no difference. If you're coagulopathic, it makes sense to give an anticoagulant, and then early intervention may also be important. But I think this was an interesting study. Furthermore, we, as a result of this and the DIC and SIC scoring, I'm currently a PI, as I mentioned, on a novel anticoagulant that inhibits factor 2 and 2A and 10A in early recognition of acute infection with sepsis-induced coagulopathy. It's a phase 2 study, but again, we're trying to understand the concept of early intervention, and you have to be coagulopathic and early infection, early sepsis. So one of the things that I'm going to sort of finish up with is a little discussion on is the inflammatory agents and the immunomodulation. One of the interesting things about people who have sepsis and they survive have persistent immunodysregulation and other abnormalities that persist for extended periods of time. You know, what's interesting, what's called long COVID, I'm wondering is if this is really a unique phenomenon, but just because of all the patients who did indeed survive, but had major injury and multi-organ system dysfunction, who made it out of that, but still had persistent issues. There's interesting stories about the use of these agents, and let me just go through some of the data. One of the interesting things to remember is in contact activation with tissue injury, all of the different things that are activated as part of the complex, both humoral and cellular amplification pathways. This is an editorial that I wrote for Lancet now 15 years ago for the CRASH-2 study. The CRASH-2 study was a study of tranexamic acid, an antifibrinolytic for patients with acute trauma. Now, one of the interesting things, there was a reduction in mortality. It's about 10,000 patients per group, placebo versus a 1 gram load, and then a gram over 8-hour infusion. What they found was that there was no reduction in bleeding, but there was a reduction in mortality. Basically, what I suggested was that when you inhibit the plasmin activation that occurs due to all sorts of issues, especially with tissue injury, that plasmin not only activates complement from C1 esterase, it produces the activation of inflammatory cells. It causes lysis of obviously fibrinogen, bleeding coagulopathy, and shutting this off is incredibly important. And there are multiple ways by which fibrinolysis and plasmin can actually be activated. So all of these pathways that get activated are important. The plasmin antifibrinolytic story is just one of the potential serine protease inhibitors that may be important. Remember, tranexamic acid, as well as epsilon aminocaproic acid, basically is a lysine analog. And what it does is it binds to plasminogen and can actually competes with fibrinogen binding, and that's its mechanism of antifibrinolytic effect. So through the years in patients, as well as in the lab initially and then in patients, we've studied multiple serine protease inhibitors for potential therapeutic, anti-inflammatory, and anti-bleeding effect. So in the 90s, aprotenin was used extensively for bleeding after heart surgery. Aprotenin is a protein isolated from cow lung. It's about a 65 amino acid polypeptide that actually has a very interesting structure. Looks a little bit almost like tissue factor pathway inhibitor. But the bottom line is that it's a very potent direct plasma inhibitor. The Ki is about 4.2. The other point is that there was a big deal made that it also inhibits contact activation because it's a kallikrein inhibitor, emphasizing that it's not just an antifibrinolytic, but inhibiting kallikrein, and all the other coagulation factors were not terribly effective. Aprotenin was used extensively, very interesting drug, and got involved in some interesting data that I won't bore you with, but was removed from the market, back on the UK and other places, but a very interesting drug and was used for many years, but not available in the US and I don't think in Canada. Another drug that I worked on was DX88 called ecalantide. It is a very potent kallikrein inhibitor. You can see the actual Ki of 0.04, less effect on plasmin, but a very potent kallikrein inhibitor. In the early era, and some of the data on aprotenin suggested inhibiting contact activation was really important for extracorporeal circulation and efficacy. So we actually studied this drug in patients. Our first study showed no beneficial effect. And then when they did a study in Europe comparing tranexamic acid and antifibrinolytic with this, the patients who got just kallikrein inhibition had far worse outcomes and higher mortality, and I'll mention that. Now, another drug that we worked on initially was a drug that came out of East Germany. It was a synthetic molecule, not a polypeptide like aprotenin, which had, I thought, a very favorable effect on, one, a very potent inhibition of plasmin, better than aprotenin, also inhibited kallikrein, and had a mild anti-10A effect as an anticoagulant, so inhibiting perhaps some of the thrombotic effects. This drug, actually, the initial work was super interesting, but a couple of patients who had surgical bleeds who got super high doses of fibrinogen, 6 to 8 grams, clotted their grafts, and as a result, the drug was stopped being studied, which is unfortunate because it was an interesting molecule and never went on to further studies. So again, very interesting application of these broad spectrum serine protease inhibitors. Let me just sort of show you that through the early aprotenin era, it was suggested that kallikrein inhibition, contact activation is important. So this was a high risk reoperation cardiac surgical patient, 100 got ecalantide, and there were 2 doses of tranexamic acid. The 30-day mortality with ecalantide was 12% versus tranexamic acid 4%. Threefold greater risk of transfusion, bleeding. And I think what this showed you is the importance of, if you're inhibiting thromboinflammation with extracorporeal circulation, contact activation is probably, at least using a kallikrein inhibitor or other mechanism, may not be important, but shutting off fibrinolysis and plasmin is important due to the pathologic responses. Now, one other thing that I would like to just briefly discuss as well is the role of complement in ischemic reperfusion injury. And I will emphasize that others in this institution have actually done some important pivotal work in studying complement inhibition. I did the work with the molecule that finally came to market is eculizumab. We studied it when it was peculizumab. The early idea of inhibiting complement was in ischemic myocardial injury, cardiopulmonary bypass, acute MI, percutaneous intervention. And as a result, about $750 million was spent in cardiac surgery and actually other trials to prevent the complement of activation that may activate neutrophils producing injury, and all of the things that happen when complement cascade is activated. There have been multiple strategies looked at. I worked with a soluble receptor some years ago in a transplant population, didn't do anything. But the drug that really became approved, eculizumab, was called pexilizumab at the time, was targeted the C5 and C3 sort of, well, specifically the C5 convertase. And that was the effect of inhibiting complement. We did 2 large studies in high-risk cardiac surgical patients, as shown. The first study that we published at VA, we presented at the American Heart, got published in JAMA 21 years ago, had some very interesting data. The fact that in early use, there was a clinically significant reduction in MI and in interesting data. And then the secondary study with a higher, the FDA didn't approve it because we missed a few of the endpoints. The secondary dose actually showed some, it was useful in patients undergoing heart surgery with extended aortic cross-clamp time. The bottom line is the drug never got approved as a primary indication for cardiac surgery or reperfusion injury in the cath lab, but rather where a complement inhibitor makes a lot of sense, and that specifically was for paroxysmal nocturnal hemoglobinuria, which was finally got approved in an orphan status and then evaluated in a variety of other important things, select thrombomicroangiopathies and other scenarios. The complement story has been around for a long time. I think it's a super interesting critical perspective. One of my other interests for decades is anaphylaxis. And the role of complement in anaphylaxis is there are multiple mechanisms by which you can produce this hypersensitivity response. Classically, IgE with mast cells releasing a multitude of mediators. But the interesting thing is that IgG, through complement activation, anaphylatoxins, and all the other things, can produce a similar acute cardiopulmonary dysfunction. And we saw it in heart surgery with protamine and some other drugs that I think have really continued the necessity for finding better molecules than protamine for anaphylaxis. And my Dr. J is doing very interesting work in that area, developing alternative molecules. So in summary, I want to emphasize that thromboinflammation is a host defense response in acute infection. Furthermore, in ischemia, reperfusion injury, extracorporeal life support, and trauma. One of the things that happens now, at least in the US, is that if you're in a major medical center, you code and you arrest, and you can't get a patient back with normal sinus rhythm or cardiovascular on inotropes or vasoactive, that they will cannulate for VA ECMO. Very interesting. The problem is that the patients usually have been in shock, you reperfuse them, they have shock liver and develop pretty florid DIC. So there are multiple causes that produce this, including ischemia reperfusion injury. One of the summaries of that thromboinflammation is the loss of endothelial function leads to dysregulated coagulation, making it a really important therapeutic target. The other important point, and at least in acute infection, early intervention in the sepsis before you have an advanced system and organ failure is important. In Japan, if you have acute sepsis, you either get antithrombin initially or recombinant thrombomodulin as a therapy, and sometimes they'll mix the two. Again, that's only in the Japanese sepsis guideline. Prior clinical trials in sepsis without DIC or SIC highlight the importance of current approaches. We did 2 analyses specifically on the thrombomodulin, and if you give it to the patients who are coagulopathic, there's a statistically significant and clinically relevant reduction in mortality. The problem is you have a very short window in order to do this. The thing about thromboinflammation, immunothrombosis, is all the cellular and humoral amplification that occurs. You block one limb, but everything else is activated. Finding drugs that are pharmacologically promiscuous across multiple inflammatory cascades are important, but maybe beyond that, using some sort of cocktail mix may be important. And thus, my last comment is future therapies need to be multimodal with anti-inflammatory as well as cytoprotective agents. And again, early targeting. Once inflammation sort of is happening, very complicated in order to reverse. You know, the active studies that used high dose and low dose heparin were revealing in the sense that high dose wasn't really that effective and more effective because once you have clot, giving more heparin really doesn't make sense. But early intervention, again, before the clot becomes substantial, is particularly important. I am an unusual American. I'm multilingual, work with a lot of people around the planet. I'm also fascinated with calligraphy. And one of my favorite kanji characters, taken from the Chinese character, of course, is the figure for blood, which is kind of like stylistically sacrifice at the altar. As a critical care physician, it looks a lot like a pleurovac. The pleurovac is the sort of the device you put the tube into the chest tube, connected to the chest tube, and you measure all the blood that comes out. And I think that it's interesting how form follows function. When they developed the actually kanji character for blood, they probably had the pleurovac in mind. And the age-old philosophical question in your pleurovac is your pleurovac half full or half empty? Thank you all very much.
Okay, thank you very much. Questions for Dr. Levy? Oscar.
Hi, fantastic presentation. I agree with you that the endothelium has a lot of.
Can you speak more in the microphone, please?
Sorry. I agree with you that the endothelium has a lot of untapped potential when it comes to preventing thrombosis and other potential events. If you had a drug that stimulates endothelial function chronically, could you think of a settings that's related to your expertise that this drug could be tested in? Sepsis is a bit too acute. There's something we don't really understand with sepsis. But if you had something that stimulates the endothelial function, in terms of.
One of the things. Okay, I talk about Mike. Sorry.
Yeah, that's fine.
So when you have a patient who's bleeding, you give them desmopressin, DDAVP. DDAVP is the V2 agonist of arginine vasopressin. Vasopressin does it, but it's a specific. Vasopressin, your circulating hormone, has a V1 effect, potent constrictor. It's circulated, released by the pituitary, and the V2 effect, which causes water absorption from the kidney. But it also releases von Willebrand factor from the vascular endothelium. It kicks it out, and therefore, you use it in one of the sort of one of the forms of factor of von Willebrand factor deficiency, where it's just about level. The problem is it's kind of like, the story, you can't kick a dead horse. I mean, the endothelium is not working and it's dysfunctional and it's injury and it's inflamed. I mean, you can stimulate it, but you need a functional vascular endothelium. Activating it, once you injure it, it goes on probably to microcirculatory thrombosis and all injury and fibrosis and all the other interesting things. The question is when intervene early enough so that you prevent that response. In addition to there's another really great article in Blood that really described the acute inflammatory response with the acute injury, thrombosis, and healing. The problem is, like in COVID, the inflammation raged on and on and on. Remdesivir didn't do anything but decreased hospitalization one day. There was no immediate kill, so the inflammation went on and on and on. Once you injure it, it's unfortunate you can't get it back. The question is, can you seed it? Can you do other things to stick in the endothelium? I mean, it's a really delicate, interesting structure. When I actually had, in the lab, we did some work on what was great in what I did in working with surgeons. You get tissue, you get skin, you get all this other stuff, and you can work with human tissues like in vitro. And the saying in my lab, what happens in man happens in man. Human tissues in vitro was what we really focused on. Blood's great for that. But the problem is to take, when you want to de-endothelialize the arterial segment, you put a little glass tube and roll it around and it's gone. So it's a great question, but unfortunately, Now, when a heart surgeon revascularizes, they take down the internal mammary artery and they put it in the left anterior descending or in the right coronary. So it's an arterialized graft versus the venous graft. So that is kind of neat. You take somebody else's, or it's too short, they'll cut it off and then, put it in as a graft. But then you're sort of transplanting it. But your question's a great question. Unfortunately, the answer, no está bueno. It doesn't work.
And you can go ahead and unmute yourself.
Dr. Conway, I see your hands up. Do you have a
Hey,
question, sir?
Jerrold. Thanks. Can you hear me?
Thank you. Thank you for attending. I'm honored.
I had nothing else to do here. No, it was fantastic. And welcome to the CBR. I had a question relates to clinical trials using multimodal therapies. What's your strategy? I mean, it's long, it makes perfect sense. We have to tackle this in a much more aggressive way to identify or to hit all these different upstream and downstream targets, if you put it that way. How are we going to do that? Do we pick and choose? Do we lower the dose of various ones and sort of tickle each pathway? What's the strategy? I mean, if you just choose, say, sepsis, which is a big killer, where we haven't really moved forward, how would you do that?
That is a great question. Can you hear me? The button, sorry. That's a really great question. I guess if you figure it out, you get to go to Sweden and get one of those cool prizes, wear the tuxedos and things like that. Actually, it's a couple of the Dukies. I've had the privilege of won Nobel Prizes. Anyhow, it's a really important question. The problem is that the more you learn you don't know. You've got so much humoral and cellular inflammation going on that targeting individual cytokines is interesting, targeting, complement, but there's so much the problem is you're always too late to the party. One of the benefits of, like, at least, let me just use an example, and sorry to back it up, but what's amazing in surgery is that you can prophylax for patients because they're going to go cardiopulmonary bypass, which is a tremendous non-endothelial interface with the reservoir where all the blood comes from the field. You've got activation epitopes. You can preemptively give a proton and antifibrinolytics and prevent the actual response from ever occurring. So that's kind of a unique scenario. People have worked on things like endotoxin immunizations. Elliot Bennett Guerrero, when he was at Duke, did some work on an endotoxin vaccine for patients who were at high risk for, GI surgery or another perspective where you have that ability. The problem is, getting the right targets is always challenging. And, when you do all these cool slides and pathways, there's so many different pathways by which you have all of these mediators. And once the system's activated, it's hard to kind of reverse it back. You have enormous expertise. I am fascinated with the complement cascade, especially from the work we did, as well as because it's interesting in anaphylaxis. And not to kind of delve off, interestingly, in the human physiologic response of shock, you see, but IgG complement to protamine or some other kind of activation is a different mechanism. You get neutrophil activation, they get aggregates in the microcirculation, thromboxane, acute pulmonary vasoconstriction, RV failure, and you can't get blood to the left side of your heart. And I've got interesting data to show that. But you got to figure out what the biggie pathways are, and early intervention's critical. You have lots of expertise. So let me spin the question back for you from all your years of experience and some really cool articles. What do you think? I mean, seriously, you have lots of insight and expertise.
Yeah, I mean, I think, the vaccination, comment is an interesting one. I mean, if we take everybody over, in my age and up, do we vaccinate all of us because we're at risk, on a higher risk, say, of sepsis if we get sick or severe disease? But then what do you vaccinate? What pathways do you target? I don't have the answers. That's why I'm asking you. That's why we brought you up from the States. I'll let others out.
So let me go to an area that I know a lot about is anaphylaxis. And I've served actually as a consultant to CBR on anaphylaxis and been studying that for 40 plus years. From the early days in the 70s where I was immunizing animals in the University of Michigan for epidermal protein, and some of them died of anaphylaxis, got an interest. Then I was a resident at Mass General. A little 2.5-year-old girl developed an anaphylactic reaction in the GI suite, and I resuscitated her, took her to the PDICU, and then continued on for the past years studying this. It's a really interesting. It's hard to study a low frequency phenomenon, but can you pre-treat for anaphylaxis? Well, guess what? For radiocontrast media, you give divided doses of methylprednisolone for like at least 3 doses, H1, H2 blockers, antihistamine. The problem is that it's not an anaphylactic reaction. It's the osmolarity of contrast is 1200 to 1400, normal osms about 280, 300, is that you get this hyperosmotic effect in people who have some funky mast cells, basophils, or whatever. Furthermore, you give corticosteroids and all these other things, and it really doesn't work because you can still trigger the responses. I think that your question is super important. And as we tried to design studies, early intervention is important, prophylaxis perhaps, but the question is finding the right targets is really important. One, I think you need to think about inhibiting complement. 2, I think inhibiting some of the cellular activation. Steroids are nonspecific, but they're not nonspecific enough. And finally, there's a really interesting quote I learned, and it's drugs that are pharmacologically promiscuous across a broad spectrum of receptors and membrane tend to be uniquely effective. And that's an interesting example. Like, for instance, treating arrhythmias. Amiodarone inhibits all of the von Williams classification, sodium channels, potassium channels, KATP channels. And when you have an arrhythmia, ventricular atrial arrhythmia, you just keep giving it and giving it and giving it till you work and defibrillate, by the way, in the interim. Other drugs, it's really finding these drugs that have non-specific effects. I think that there's still hope on the planet, but it's a challenge. And I think the best part is it leaves us with stuff to do. And young individuals out there, use the force and figure it out. Thank you so much.
Yeah, I've got a question in relation to complement. Basically, you've mentioned complement several times. Heparin was originally described as an anti-complement agent before people realized it was an anticoagulant. In your studies, did you see any real place for heparin or not?
I'm not sure. I heard the question.
He's asking about heparin is originally developed as an anti-complement agent. So in your studies, anything you've seen?
That is a really important perspective. And actually, it was John Weiler in Iowa who did a lot of this work showing there's fractions of heparin that are C1, that are complement inhibitors. Your point's extremely important. The problem with unfractionated heparin is that it's a multiplicity of different monomeric and polymeric forms. I can tell you also that there are cases where patients get protamine. It's probably an IgG reaction where they acutely pulmonary vasoconstrict, where they're dying, their right heart's failing, and you bolus with heparin, and things get better. This is a really interesting concept and a very important perspective. But really, you're totally right. It is a very potent complement inhibitor, interesting molecule, but once the reactions occurred, reversing it can be super challenging. And again, that's a great comment and very important. But and I think actually one of the things is that there are people now working on these as potential anti-complement agents. Cobra venom supposedly is as well. No, that activates complement. I'm sorry.
One point you made was about the sort of the polymeric nature of heparin, molecular weight 5,000 to 36,000. Low molecular weight heparin, has anyone looked at that specifically? Because it may have a different spectrum of activity.
He's asking about low molecular weight heparin.
Yeah, low molecular weight heparin. low molecular heparin is heparin purified at 3,500 to 5,000. I mean, I don't know, my understanding, low molecular heparin is really not my expertise, and I'm going to sort of pass on that one. But I just know that, and I'm not even sure what the fragments are that are so helpful. This is again John Weiler's work, and unfortunately, I've been a while since I've ever looked at it. But I don't know. What do you have a thoughts about this?
Maybe like,
Uh,
we have one more question from the online. Dave Farrell, can we move to the next question?
Sure, of course, of course.
Dr. Farrell, you can go on.
Thank you. I had a question about the efficacy of heparin in the COVID patients that you mentioned. And there was a large New England Journal study that showed the futility of giving heparin to critically ill COVID patients. And what I found interesting about some of the data you presented is that levels were so high in them is that it isn't just total heparin or total fibrinogen that's raised in those people. It's a specific isoform of fibrinogen, the gamma prime isoform, which has a high affinity thrombin binding site. And Jeff Weitz showed several years ago that when gamma prime fibrinogen binds thrombin, the thrombin is completely heparin resistant. Antithrombin cannot get in there to inactivate it. And so I wondered if you have done any comparison studies in, let's say, COVID patients with high fibrinogen levels, whether other anticoagulants besides heparin were more efficacious than heparin itself.
Yeah, the gamma prime fibrinogen is very interesting. I know of that's some of your work, isn't it? And Cheryl Mayer at Emory is also very interested in it with its differential effects. This is not my expertise, to be frank. The problem, though, is realistically that once you've got clot formation and it's giving an anticoagulant is not really terribly helpful. And the problem with the hyperfibrinogenemia, in addition to the gamma prime, is your levels are so high that, just activation occurs. Unfortunately, the active studies were challenging. I think they were important because nobody knew whether high dose or low dose. But the bottom line is, I think we all also know that once clots form and there's microcirculatory thrombosis, heparin's not terribly effective. For an acute response, using it as a potential complement inhibitor and within like a short, minutes or something makes perhaps more sense. But when you start talking about dysfibrinogenemia, that's kind of beyond my expertise. Important question, but again, high levels of fibrinogen, self-assemble, and all the other interesting things. It's interesting because in critically ill patients, I've had fibrinogen levels as well as high as 1,200 to 1,400 milligrams per deciliter. And I mean, these people would actually form clot. And the best part was when I had to put a central line in them, I'd put the blood in the tube and put it on the field. And then within about a minute or two, it clotted and I send a fibrinogen level is super high. So again, the hyperfibrinogenemia is problematic, but as well as I think in the dysfibrinogenemia you talk about, again, not my expertise, but very important point. Thank you for your comment.
Thank you.
Any other questions from the audience? One last question.
Jay's indulging me. Further to this idea that coagulation, complement, and inflammation are really just one great big pathway. In your eculizumab study where MI went down, did D-dimer and thrombin antithrombin complex also go down?
Yeah, we didn't measure. We measured just about everything but that.
Any other coagulation parameters?
The standard stuff, but we did 8,000 patients pretty much in the data. We have a lot of CKMB data. We have lots of other data. The interesting thing, we also had the concern about inhibiting complement in acute infections. One of the interesting things was that the infection rate was lower in the patients who got the complement inhibitors. It was lower. And these people, have major bacteremia that occurs with surgery. When you're doing a zillion labs and the FDA doesn't tell you to do D-dimers because that's not a major concern, but they did do white cells. And again, the issue, interestingly, was the infection rate was lower in complement inhibited patients because there was New England Journal study around that era suggesting it was a higher issue with infection. Interesting question. Your point, though, I think is really important. Nature didn't design a system. It designed a synchronous system that all works in unison. And all of these pathways are like, I still kind of think it's quirky taking thromboinflammation and causing it immunothrombosis being different. But, we did a guideline document for the European Society of Cardiology, and I got in arguments with the cardiologist that it was the same thing, and so we separated it. But it's one continuous system with all of the systems interrelated. It's fascinating, and because of all those arrows, you're going to be darn challenging to find the actual formula for inhibiting. But an ounce of prevention where it's a pound of cure, if you can figure that out and get it on early, perhaps that's important. Again, the anticoagulation story with a sepsis induced before it goes into overt DIC is important. And we're trying that again. These studies are really challenging and doing sepsis studies. But what do you think? And I think you've done a lot of interesting work with complement as well. What are your thoughts?
Well, I'm just going to add to what you said, and you're highlighting plasmin in this context, which is a very, very low fidelity protease, and we still haven't tapped all of its known functions. It can signal cells as well as it has many solution phase substrates. We're just in the genesis of understanding what plasmin is able to do. So I applaud you in highlighting that in your talk. I don't want to slow down the extent of this symposium. Jay is itching to say thank you very much.
I want to. Can I just do one thing? I want to second that motion. I don't know about you guys, but there's a great scene from Gladiator where he's riding up and down. And remember, he says to start the war, he goes, unleash hell. Let me tell you a story that in the patients on ECMO with the chest tubes, when they'd clot, they used to inject TPA into them until, guess what? Somebody injected it and it got absorbed into the system. And then all of a sudden, whew, we just like bled like stink, unleash hell. Plasmin, we tried to develop a fibrinolysis model in my lab years ago. And when we gave plasmin in the blood, it clotted. Plasmin chews on everything. It activates thrombin from prothrombin. It creates all sorts of, it's a pharmacologically promiscuous enzyme that does all sorts of crazy stuff. It's a C1 esterase activator. It's really, that's one of the reasons why in nature it circulates at such a high level. And we've used those levels. One of the reasons is that when I'm working with Dr. Sullinger, and we did work with factor 9. The problem was 9 didn't do much, and you got thrombosis when you did off-pump surgery because tissue factor, and you and I discussed it, is a really major driver. So then he says, well, we're going to add a 10 aptamer inhibitor. And I go, why don't you go for thrombin? He says, because factor 10 is such a low level that it makes sense you need, but using the synergistic effect, I don't know. You don't know until you run the experiment. Wasn't my idea, but anyhow, he did his postdoc with Jennifer Doudna, so I kept my mouth shut. But anyhow, thank you all very, very much.
Levy again, and welcome to CBR. Thank you very much. Okay.
Jerrold Levy, how are you?
Hi.